12. Okay, our next speaker is Professor Richard Layte, someone well known to all of you as someone with a long-standing and very keen interest in Irish healthcare, and also in the role that health care and health systems can play in improving all our health and our well-being. He's Research Professor at the Economic and Social Research Institute and an Adjunct Professor at Trinity College Dublin. And in particular, his research looks at the fundamental processes which influence the distribution of health and well-being in societies, and how these are shaped by political economy and the structure and functioning of healthcare systems. So to talk on health service reform in the programme for government 2011 to 2016, what are the issues and what has been promised? Professor Richard Layte.
Good morning. Thank you very much, Maurice. Now, my role today is really to precede the other speakers in terms of laying out what the problems are in Irish healthcare and what there is in the programme for government in terms of dealing with those problems. Okay, so I'm going to talk to you about what I see are core issues, but I'm not going to go through many of the operational issues. I am going to keep at quite a macro level in terms of architecture and particular issues that I see facing Irish healthcare. Okay? Why don't I start first of all by just putting the Irish context in an international one and talk at a general level about what problems Ireland faces. Well, of course, there are many problems that Ireland faces. Some are common to other nations. So, as it says up there, we're experiencing demographic change. We've got an increasing population and an ageing population, like many other countries. Our processes are not as severe as in some, but we have significant ageing. There's epidemiological change. We're seeing worsening health in some respects that may lead to pressures on healthcare in the medium to longer term. At the same time, we've rising expectations for care. People expect more of healthcare now. They expect more healthcare and they expect higher quality healthcare than they did in the past. And that has implications for cost and for services. Costs are rising in part because of pharmacological technology. That has been a particular pressure on Irish healthcare over the last decade, or more actually, but it's been a significant cost. And we see, like other nations, that we have public waiting lists for care. This is not something that Ireland experiences alone. This is an international experience. Like other countries, we also have relatively poorly integrated systems of healthcare, which are far too focused on hospitals, with less focus than there should be on areas like primary care and integration of services. And lastly, we share, like many other countries, economic crisis. Our economic crisis might be slightly deeper than many others, but many share that same thing. Now, those are international comparisons and things that we share, but there are more specific issues which are specific to Ireland. We have a system, this is kind of underplaying it really, a complex mix of public and private care. To tell you the truth, it's a health economist's dream, the Irish system, in terms of looking at the integration of the different components of public and private care and what that means for utilisation patterns and for outcomes. It leads to a very complicated system. We also have a system, a complicated system, if you like, of a mix of voluntary and religious organisations delivering care, with all of the variations that means in terms of management and governance systems. Some see that as a strength of the Irish system, but it also has a downside too. And, last of all, we have a historic rather than needs-based system for distributing resources through Irish healthcare. We're not alone in that amongst other countries, but most developed economies would have a model for how they distribute resources, not one that is based upon a legacy in history. I'm going to talk about all these things in more detail in the talk to come. Okay, and as I say, I'm going to take a particular approach. I cannot deal with everything. I'm going to avoid talking about mental health care services. I'm not going to talk about issues like pharmaceuticals, even though they're a really important issue that drive costs in many ways. I'm not even going to talk about integrated care, which is a really important part of the changes that are going to be happening in Irish healthcare, and which the Minister's already talked about today. But I am going to talk about what I see as being important tenets, if you like, of healthcare. These are architectural structures that you need to have in place. So first of all, you've got to have guiding principles for the provision of healthcare. You've got to set out with a principle in mind and not just respond, if you like, to events and bring in ad hoc changes in policy to try to improve policy. You should set out with an objective in mind, because it will help you to align, those principles will help you to align your objectives. Secondly, we've got to pay attention to the microarchitecture within healthcare and align those incentives for the different individual and institutional actors. That sounds like an overly economistic approach to things, I know. But the third point there of having macro-level structures which guide and regulate, okay, needs to happen with that alignment of the microstructures happening in tandem. That at the macro level, you have, as I said before, a resource allocation system which is based upon evidence and needs assessment. So there you're assessing across your population where health is worst, where need is most, and directing resources at that. And you have national standards that you should be adhered to, that you are then implementing locally. You have national entitlements, quality assurance and audit. All of those requiring information and evidence and data. But while you put those things into place, you then need to have that micro-architecture working too for you. And what I'm going to do is, I'm going to walk through different areas of healthcare now, talking about primary care, talking about hospital care, and I'm going to bring out those three key aspects as I do so, okay? So first of all, just before I talk about healthcare services at all, let's understand something of that demographic change, because I think we need to know something of the backdrop upon which healthcare reform is happening. Is it a sympathetic backdrop, or is it one that we're going to find that is quite adverse? Well, actually, it's quite a tough environment in which to carry out reform of healthcare. Here's the total population of Ireland from 1950 to 2010, and as you can see, it's been going up, and it's been going up very strongly, particularly over the last 15 years or so. Now, the drivers of that are fairly easy to find out. Total births have been going up. We've a population which has not only got a high fertility rate in international context, but we have a population which is we have a particularly large cohort of people coming through now who are of fertile age. That's leading to a large number of births, and that's going to have consequences as the population gets larger, and particularly in terms of the way that that population is distributed, because some areas, particularly around the large cities, have got a change in population makeup, which is going to have a pressure on healthcare. Secondly, the number of deaths is going down, so people are living longer. Now, that's a good thing. It's something that we should all cheer, that Irish people are living longer. But it's, of course, going to have consequences. As you can see there, the death rate and the overall number of deaths was dropping quite severely after the turn of the century. There are particular reasons for that I can talk about if you like, but the net result is that with more births and less deaths, you have a bigger population. And less deaths also means that you have an ageing population. People are living longer, therefore the average age of the population gets older too. And that has consequences, of course, for the types of care that people are going to require. So, just give you a couple of key facts. Even if we have no emigration at all, and there is still net positive net migration into Ireland, then we'll see a population increase of about 11%. And of course the growth in older people is largely independent of those changes in migration. So the proportion of people over 65 is going to be increasing to 2021 from 11 to over 15%. The number of older Irish people above 85 is going to be doubling. Okay, so going back to the minister's metaphor of the alligator swamp, we're facing both an adverse fiscal environment, economic environment, but also an adverse demographic environment in which to implicate, to make reform happen in healthcare. That's very important. We're going to have to get more healthcare for more people with less money. That's going to take whole-scale change in structures. It sounded from what the minister was saying that they're not afraid to go there and do those things, but it's going to take a lot of reform. Well, let's look first of all at primary and community care. I'm going to be talking largely about GP care, but of course primary care is a lot more than just GPs. It's a whole realm of different professions who are contributing to care in the community. That means all the different professionals, but also things like long-term care. Arguably, reform of primary care is the most urgent change necessary in Irish healthcare. It could be the key to reform of Irish healthcare more generally. The Irish healthcare has to be looked at as a system, as the minister said. You can't look at any one piece, but some are very, very important. And the primary care strategy from 2001 laid out a route map to reform of primary care, which I think is generally agreed by most people to be the appropriate route. General practice carries out the majority of healthcare, both in Ireland and in other countries. About 80% plus of medical care happens within primary care, as it should. And because of that, primary care is a big spender. So you can see there in 2009, growth expenditure in primary care was 8.2 billion, or 56% of the total HSE spend. Arguments could be put forward that should be more in terms of efficiency and in terms of returns, in terms of health. 40% of that 8.2 billion goes to GPs, GP services and to pharmaceuticals. Now, what are the challenges in primary care? Well, first and foremost, there is this basic differentiation between public and private patients, with the poorest 40% or so of the income distribution receiving free access, and the market rate, essentially, for primary care or for GPs for the remainder of the population. This has become more complicated in recent years with the GP-only medical card and with private health insurance that covers access to GPs. But it is this mix of public and private in primary care which distorts the pattern of utilisation and creates many of the problems that we see. And it has particular effects in terms of the incentives. It means that we have financial considerations influencing utilisation patterns that really should be based upon need alone, for the most part. We have the private patients disincentivised to use, particularly those who are just above the medical card thresholds. Those patients face a big disincentive to go to GPs, and you see that in terms of the patternings of utilisation that we see. We have a structure which disincentivises GPs from spending time with those GMS patients because they're paid for on a per capita basis. They get an allotment of funds for each patient. Therefore, they can't increase the amount they earn by seeing more of those patients. They can only do that via their private patients. Now, I'm not saying that that necessarily happens, but it's a structure of incentives that leads in that direction. This is the result. This is what you see from some of the studies that have happened at the ESRI. I'm grateful to my colleague Anne Nolan for supplying this data. It comes from some of her studies. What this shows you is basically the probability of going to the GP. You can see on the left-hand side you've got those with a medical card and private health insurance. Then the medical card only, GP visit card and private health insurance, GP visit only card as we move to the right, private health insurance only, and then no cover. And it has this beautifully structured relationship. Like I say, the Irish healthcare system is a dream for health economists. It means that we can do all kinds of really intricate studies looking at the patterns of utilisation, and it delivers. And these patterns are even adjusting for the health status of the person, their age, sex, lifestyle, income, location, and other factors. Okay, so you could say that this, in a sense, is the outcome of that structure of disincentives that we see. You could argue, of course, that it's overutilisation on the far left-hand side. These people are using too much, whereas it's underutilisation on the right-hand side. It's difficult to have permanent evidence about that. But irrespective of that question, clearly the system leads to differentiations in utilisation which are not based upon need. They're based upon the structure of the financing structure instead. That's wrong. We need to change those things because it leads to poor outcomes. What are the other challenges in primary care? Well, there's an incoherent long-term illness scheme which is interacting with financing to exacerbate those problems in terms of dealing with chronic disease. Chronic disease is the biggest issue that we face in terms of areas of illness. As I said, the population is ageing and growing larger. Chronic illness is already the dominant generator of health need. It's 60% or more of all consultations are through issues around chronic illness, different kinds of chronic illness. And that's the long-term illness scheme doesn't help there because certain individuals with certain chronic conditions are getting free drugs, but not others, and none of them are getting free care at the moment. There's no coherent national approach to or incentives for primary and secondary prevention. That's really important. It's much better to prevent people getting ill than to treat them once they're ill. It's much more efficient, much more cost-effective, and it's better for them in the long run. We've got very complicated and opaque rules about eligibility for other public health services for patients. This is important when we have a primary care strategy which is meant to be bringing teams of GPs together with other professionals. And yet when that happens, it's very unclear of who gets what services at what cost and why. We have a tiny proportion of GPs working in true primary care teams, more than a decade after the primary care strategy. And the majority of private consultations obviously means that there's a quite transient relationship between patients and GPs. This is bad for relationships between patients and GPs, it's bad for record keeping and for good continuous care. That also has a cost, of course, for the information systems and for the coherency of prescribing. So those are important issues. What are the solutions? This goes back to my tripartite slide at the beginning of the presentation. The principle should be that utilisation on the basis of health need through equal access for all through a system which is free at the point of delivery. Okay, that should be the principle. And that should then lead you to your objectives that you've got around primary care. That should mean that primary care is free at the point of delivery, It has to be paid for. Okay? Now, how you go about paying for it is a different issue. And there are a number of financing routes that we can take. But all patients need to be seen by GPs on the same basis. There was a plan put forward in the Rowan report from 2010. Francis Rowan is the director of the ESRI, and there was an important report on the expert working group on health financing, which Francis chaired. It put forward a system whereby that would lead to equal single-tier access to GPs, and it put forward a route map as to how to get there using stepped changes in primary care eligibility, okay, which was to do with extension of the LTI scheme to other chronic conditions. They were putting forward different levels of co-payment and essentially, over time, bringing in single-tier access. Now, in the programme for government, what do we see in terms of what's going to be provided? Well, importantly, they're talking about higher numbers of GPs and other professionals, which, given the growth in the population and given the growth in the intensity of care that's going to be needed because of ageing, is going to be an important outcome. More GPs means better care, and it's particularly important if you try to bring larger components of healthcare into primary care instead of in hospitals. There's an extension of the free care to long-term illness claimants in the first year of the programme for government. Free care for high-tech drug scheme patients in the second year, and then free care for all by the end of the first term. It's not adopting, as far as I could see, and if I'm wrong here, maybe someone could enlighten me, it's not adopting that stepped approach that was put forward in the working group's recommendations. But the important step of GP registration will be implemented there when the single tier access comes in. There will be a new GP contract which will be incentivising integrated care of all for chronic illness. Now that's actually put down quite boldly in the programme for government, and that's a complicated animal, and there's a lot of detail that clearly needs to be put in place to make that happen, about how it's going to work. And so the design there should take into account aspects of quality insurance, incentivising preventative care and facilitating the audit of the care that GPs are providing. Going back to my slide at the beginning, we need to think about the data that is available to us to do analysis of what clinicians are doing, so that we can, it's not just about policing clinicians, it's about shaping the system, tweaking the system, and making sure that we use evidence and rational planning rather than trying to respond in toto from a sort of macro perspective. Let's talk about inpatient and outpatient hospital services. What are the issues here? What are the problems? What are our challenges? Well, long public waiting lists for treatment, which are, of course, worsened by fiscal crisis. It was good to see the Minister today talking about trolley numbers and waiting all going down, but it is still true that the fiscal crisis has meant bed closures and growing waiting lists for many conditions. We see acute hospital space being used for long-term care because of a lack of other options, so that in hospitals we have longer length of stay than other countries. We have a possible kind of interaction between the financing system we have in hospitals and the long-term stay here. In that, as the Minister was saying, although you have beds being taken up in acute hospitals by individuals who really should be in another location where there are more appropriate places of care for those people, it's not in the hospital's interest to move those people into those other locations, because in doing so those patients tend to be older, and although they need care, their care tends to be quite cheap. Whereas if you bring in a more expensive younger patient that has more intensive care needs, that might cost more. There are these kind of interactions going on in the system. The incentives then leading to the care of that person in a very expensive acute hospital bed rather than in the more appropriate, more efficient primary care setting or community setting. There's a lot of potential for efficiency improvements in inpatient care and outpatient care in Ireland. So one of the things that the ESRI has done quite a lot of research on, particularly thankful here from my colleague Jacqueline O'Reilly, who's done some research on this, is, for instance, in day case procedures. That the amount of day case procedures in Ireland has been going up. And that's important because, of course, if you can have people being treated on a day case basis, they're then going back into the community and cared for, as long as you have the appropriate quality assurance there and you have the appropriate care after their intervention, then that's fine. And it means that you get cheaper, you get more care being carried out on a cheaper basis. Ireland internationally has low levels of day case. It has been increasing, but it's still low. And that's, again, contributing to this long average length of stay. And there's a number stay up there, almost 9,000 extra day cases would be performed if all hospitals increased their use of day case up to the upper quartile. That's equivalent to almost 21,000 bed days that will be saved in Irish healthcare. Just an indicator of, if you like, the efficiencies that could be gained. There's a real, and I'll just show you a slide actually about, or a couple of slides about the efficiency gains that could happen. This is a slide that's showing you variation both between and within hospitals, okay, in terms of day case rates. Look at the diamonds. Okay, the black diamonds represent the medians within each hospital. As you can see, the median level of day case across the hospitals varies wildly. They're almost randomly scattered across that graph as you go left to right, aren't they? So it's not as if they're all going down towards a particular proportion. So clearly, hospitals vary in terms of the extent of day case that they carry out. But look at the red X's and the blue lines. The red X's are the maximum number of day cases for any procedure in each hospital, and the blue lines are the minimum. And you can see that within most hospitals, the X's are pretty near the top, and the lines are at the bottom. That means so within hospitals, there's huge variation in terms of use of day case across different procedures. So there's room within most hospitals for improvement in the amount of efficiency that they have. Let's look at that in terms of length of stay then, and variation across hospitals in terms of length of stay. This graph has, if I'd have shown you data from 2000 versus 2006, there would have been more spread in terms of hospitals. And the X's represent the length of stay in 2010. So what you want to see is average length of stay in 2010, the X's being below the triangles. Now actually, they're above in about a third of those cases. Okay, so length of stay has increased in about a third of those hospitals over the time period between 2006 and 2010. And also hospitals vary quite significantly still in length of stay, although I should say there have been improvements. So there's an issue about efficiency that really needs to be dealt with here, and it's putting in place a structure and a change reform which is going to lead to that improvement, which is important. What is the solution? Well, we should be, of course, thinking here about the principle involved, and the principle is high quality, cost-effective care in the most appropriate location. There used to be a slide there that said that too. I'm not quite sure where that's gone. But that's kind of mother and apple pie, except there for the most appropriate location. But if you have the principle in mind, then that should lead you to think about how you organise your hospital services so as to make sure that patients are being treated in that most appropriate location. And if you do it in the most appropriate location, that should have connotations of efficiency in there too. Now, how do we change hospitals so that they do become more efficient, that we get, if you like, higher performance from the same level of resources? This is always very, very difficult. Hospital governance and reform, there's a library of research on this out there, and there are many commentators, and if you go into any bookshop, you'll find plenty of books on it. It's always difficult. I don't think there is a universal answer to this, because, of course, you've got the situation where you've highly skilled clinicians working in an environment where they cannot be directly managed by non-clinical management, but they still need to engage. And it means changing a lot, if you like, of the understandings that clinicians have about their role, that they need to step up and become part of that management structure. And they need to adopt practices that are broader in terms of their scope. That it's not just about providing the best care, it's also about providing cost-effective care too, and thinking about the whole patient journey and pathway through health care. That might need changes in the skills that those clinicians have, and that means having ongoing professional development and trying to bring together integrated care across clinicians so that clinicians are responsible for the quality of care and cost effectiveness of that care too. I'll give the example here of if you think of an airline, that a pilot has to get an aircraft and his passengers or her passengers from one place to another safely in the fastest time possible, because that's what the passengers want, and they are obligated and regulated to provide safe transport. But at the same time, they should do that in a cost-effective manner. They shouldn't rev the engines up to high power and use as much fuel as they possibly can to get there. They have to use cost-effective methods to get their passengers there safely. And doctors are in the same situation in some ways. They need to provide safe, effective care, but they need to do that in a cost-effective manner. At the moment, there isn't really a set of incentives on doctors to have a view of what their treatments cost. Quite often, they don't know what the treatments cost that they're giving patients. They don't even have a view to the pathway that their patient is taking through their department and into the other parts of the hospital. And there isn't a care plan accompanying that patient. Those are things that really need to change. And it's been something that has been put forward in things like the clinical directorates, but implementation at that level is still ongoing, I think. What are the other solutions? Well, as well as promoting change and reform within hospitals, we can promote hospital efficiency from outside too, and that means changing the financing of hospitals themselves. It means putting in place a purchaser-provider model. But what does it mean at the moment? Well, currently we have hospitals which are largely financed on a historic basis. We pay providers to exist with retrospective payments. They get fixed reimbursement for a specified time period that's not linked to their activity levels. It's just paying them essentially to exist, and they're paid what they were paid last time, plus or minus some amount. There's no incentive there to reduce costs at the hospital level. The risk of cost overruns is going to be borne largely by the funder, by the HSE, by the taxpayer. Hospitals have no incentive to keep within their budgets that they have, although there's been more of a clampdown on that issue in the last period. There's no incentive there for cost-effective treatments, to adopting different technologies or different approaches to interventions that might bring down overall costs. And there's a possible incentive to promote low-intensity treatments for patients above the more intensive ones that might be more costly. Instead, hospitals should be paid on a prospective basis. You have separate commissioning and provision of care. That is, you have one agency that is contracting with providers to provide care of a specified amount. In that sense, then, it's prospective. You're contracting before the care is undertaken, and there's a specified amount of money being exchanged for those things. That leads to some of the risk of overrun then being borne by the provider of the care rather than the purchaser. That type of prospective payment encourages more low-cost, efficient healthcare provision. It's not always easy, because hospitals themselves have to reform to provide it, but there's a pressure exerted to move in that direction. It does have a difficulty in terms of some of the incentives that might crop up. So if you get a very efficient hospital, for instance, which provides all of its allotted care that its initial contract stipulated quite early, their incentive on them is to then stop providing that care and take the, if you like, the remaining funds available and put them to other purposes. So you might want to think about changing the contractual structure so as to maximise, like, the amount of treatments in particular areas that you might receive. There's a kind of perverse incentive on hospitals to avoid complex cases here and long stay cases. And again, you need to think of these things in terms of the design of the systems that you put in place and the design of the contracts and the relationships that you have. But going back again to the first slide, it's important to have those incentive structures in place, just as you've changed the macro structure in terms of the contracts that the purchaser-provider contracts. Okay, so you need to have the principle, the structure and incentives all in place to all work in the same direction. And of course, based upon evidence. Lastly, in terms of reform of promoting hospital efficiency in terms of that long stay case, and in terms of the integration of care, it could of course be that many of the problems that hospitals face in terms of long stay are only answerable from elsewhere in healthcare, that the answer to those things might actually be in primary care, that the healthcare needs to invest in more primary care and in a sense a greater range of care that can be provided so that people can be treated in their own homes with the support that they require there, or in more long stay environments. But essentially this is that part about providing care in the most appropriate location, because that will have consequences for the whole system overall. What's in the programme for government? Well, we have universal health insurance by 2016 within the programme for government, and as the Minister said this morning, multiple health insurers. This is going to be a large issue within the reform process, and I think there are going to be many people today who will put forward the point that there is no evidence necessarily that will have an impact. In fact, it might have negative consequences in the Irish context because of the scale and the makeup of the Irish market. What it will provide in the programme for government is single-tier access to public hospitals, so everybody coming to public hospitals on the same basis, and insurers not allowed to sell faster access to procedures covered by the UHI practice package. So insurers will be able to sell insurance that gets you into private hospitals quicker, but they're not going to be able to sell treatment that gets you into public hospitals quicker. That'll be quite a change, because at the moment, most people, according to the research that we've done at the ESRI, most people buy health insurance for quicker access. If that changes, that really does change the incentive structure. Hospitals are going to become not-for-profit trusts. The Minister was talking about that earlier on. That has real consequences in terms of fund holding and in terms of the amount of control that hospitals will then be able to exert on their own business. It does have implications as well, though. The programme for government is quite bald about that, but of course, what does it mean for the way that hospitals can deal with their cost basis? Most costs in hospitals are to do with labour. They're to do with the human resources in those hospitals. Are they going to get more leeway to change the types of payment that they, or amount they pay for those things? We get the creation of a purchaser-provider system for prospective purchasing of care within the programme for government, and the hospitals being across the system, an incentivisation based upon money following the patient. That's a simple thing to say, but a complicated thing actually to deliver. But that's what the programme for government is saying. And lastly, it is putting in place that macro-level regulation that we were talking about in terms of a licensing system for hospitals that gives bite to national standards being applied at local level. Lastly, let's talk about the needs assessment, a resource allocation model in the Irish context. This, I think, is very important, and it's something which a number of other countries have, because it provides for the allocation of resources in pursuit of national objectives and on a strategic basis, so that you recognise where there is health need and you direct resources in pursuit of that. Now, currently, our resource allocation system is historic and not evidence-based. It's based purely on how we spent money before and where we've put capital investment, and where that capital investment didn't necessarily go into any one place for a strategic reason. This means that services are often funded without an integrated strategic plan as to their role in the overriding health system. We have no national population health needs model, which I think is an awful state of affairs, given that that's key in many ways to providing people with quality healthcare irrespective of where they live. Now, Anthony Staines did a good job for the Health Research Board looking at how we could build a resource allocation model. And in his analysis, he showed that there's a wide discrepancy between a basic model of a basic resource allocation model and the actual distribution of resources at local health area. What he showed was that even if you take a very simple model, that at the moment the way that we allocate resources is far off this, which suggests that we're directing resources in completely the wrong direction in many places. That's very important. We need to base policies and we need to base services on evidence, not just on the past. This would suggest that we need a transparent resource allocation model based on population need. So, in conclusions, and I'm probably overrun just a tiny bit, Maurice, I'm sorry about that. The programme for government has really benefited from a lot of detailed work that went on, that went into the Labour Health Manifesto, that itself was based upon some research that had been done in the period before the election. There was a publication of a number of reports that provided evidence that could go into that manifesto, and that was then integrated into the programme for government. There was the HRB project on the impact of demographic change that you saw some numbers from earlier on. There was Anthony Staines' HRB resource allocation model for Ireland, and then there was the Rouen report, the expert group on resource allocation. Now, the programme for government does provide the principles, structures and appropriate incentives for a much more coherent and effective single-tier healthcare system. I think that needs to be applauded in many ways. And the model seems to be a good, appropriate one. The financing of that and the detail in terms of the contracts for GPs and how we make the primary care strategy from 2001 actually work on the ground is a more thorny issue. It's unclear what form the reform of hospital financing is going to take. We have the major components there in the programme for government about independent trusts, about money following the patient, but these are things that are macro level. We need to put a lot more flesh onto those bones. Lastly, there's nowhere in the programme for government a mention of a resource allocation model. It might be that this is too blindingly obvious to be put into the programme for government, in which case that's a good thing, and it means it's being done. If it isn't something that's going to appear, that will be a sad loss in terms of Irish healthcare, because it's very necessary. So I'm going to stop there. Before I do so, though, one thing I do want to say is this is a really important time for Irish healthcare. It's quite exciting in a sense to be here talking about and being in Ireland at a time when there's going to be such momentous change in healthcare. It's also, in a sense, happening at the right time. It's strange to say it, but the fact that there is a fiscal crisis going on might be the impetus we need for the kind of deep change and reform that's required. Maybe instead of seeing this as a problem, we should see this as an opportunity that's available to us. And I'd like to make a parallel to Britain in 1948, when the National Health Service came into being. Clement Attlee's Labour government that came into power in 1945, was it 45 or 46? But Clement Attlee's government, Labour government that came into power, was absolutely broke. Britain was broke. Britain's day-to-day expenditure was based upon loans from the US. It wouldn't pay off its debts to the US until 1986. It was paying payments to the US until. When the NHS Act was put forward, the white papers were put forward, there was much in the way of opposition to it. People said that you can't give people access to healthcare on a free basis. Healthcare had been a commodity up to that point. It was expensive, it was irregularly distributed across the population, which meant that many people didn't get appropriate care. And many of the vested interests said that it couldn't be done. If you give people free care at the point of delivery, what that's going to lead to is limitless utilisation. You'll just bankrupt the country. There's no way it can be done. It's against all laws of human nature and economics. But they did it. They put in place the National Health Service in 1948. It wasn't perfect. There were many problems. It went on to develop over time, and iteratively, it got better over time. It's still not perfect in many ways, but there was a principle that was put forward as being necessary at that point. And then they worked towards the principle. And I think that's what's important. Ireland is in a very similar situation now to Britain in 1945 and 48 in terms of the need for establishment of a healthcare system based upon a principle. Okay? And I would have high hopes that we can do it. And I'm quite excited that we can do that now and take it forward. Thanks very much.
With which you tackle the whole issue, it's lovely to have that sense of excitement. But I guess maybe the true measure of us having a properly egalitarian system might be when the likes of Richard are terribly unexcited and bored, and maybe that's sort of where we're going. Okay, you're here to take some questions. Are you anyone?
My question really is in relation to the whole concept of universal health insurance. We've heard lots of very positive references to the NHS, but obviously this model that's being contemplated isn't the NHS. What we're looking at is a major attempt to simplify the Irish model, which is immensely complicated. But the simplification, it seems to me, and it was helpful that the Minister said that we're not going for the Dutch model, we're going for something else. So the question is, what are we going for? It seems to me that the simplification is very much more in the direction of marketisation of healthcare and healthcare financing. That primarily we're talking about a private financing model of healthcare in which the state steps in to subsidise those who can't afford to pay the premiums. And that is a very different direction to be going. And I think we need a bit of clarity about that and about the potential costs and benefits of it. Because although there are imperfections in the British NHS model, there are huge imperfections in privately financed models of care.
Insurers are not going to be allowed to differentiate between individuals in terms of their overall risks, in terms of their need for health care. They're not going to be allowed to charge older, sicker people more. So the extent to which it's an insurance system will be quite limited. There's going to be a lot of elements of solidarity, social solidarity based within it, that insurers are going to have to offer the same package to everybody in terms of access to hospitals and primary care, and then they can add on components onto that, but essentially they can't allow people to buy quicker access into public hospitals. And in doing that, they're pursuing that line because they feel that having multiple insurers gives them control of healthcare costs, and particularly the restraint on future increases in healthcare costs. I can see the logic of that, but whether that will cost, but at a basic level, they have to replicate and duplicate the same structures that their competing insurers have. That means that you have more administration costs overall. So generally speaking, if you look at the US system, the administration costs something like 25% of overall burden compared to something like 6% in something like a universal system like the NHS. So it has costs involved in pursuing that line, and there has to be a question asked as to whether, in pursuing that model, you even get the sort of the effective competition that you want. This is a population of 4 million people. Okay, even for a basic financing system where you have some sort of purchaser-provider model, 4 million people, it seems to be the absolute minimum for having sort of an effective, if you can say, model of purchaser-provider system within it. It's not enough to have multiple insurers. There's another line of argument as well, that in putting in place those multiple insurers and trying to get that competition working, of course, you have to try to make sure that they're playing on an even playing field, which means having a complicated system of risk equalisation across those insurance companies. That's going to be really difficult to maintain. The government's already found, the previous Fianna Fáil government found that became unworkable, and that they had to put in place more and more complicated structures in terms of the payments that the insurance companies were going to have to come up with. I don't think that's going to be workable. Or if it's going to be workable, it's going to be unstable, and it's going to be difficult over time. They're going to have to keep on fiddling with it. So there are a lot of questions about the model that's being adopted here. There are many good things about trying to provide single-tier universal access to health care. But healthcare systems are notoriously difficult to create a competitive market within. It's almost impossible. The British have been at this, for 30 years, trying to put in different elements of competition within the NHS and failing miserably. And the latest changes that have been made by the Cameron government are just another step in line there. The Dutch system has not necessarily been great in terms of providing that competition, and we'll have some commentary later on today from another speaker on some of the experiences of countries like Switzerland and the Netherlands. So I think there's an awful lot of issues that still need to be played out here. It was interesting to hear the Minister saying that this was something that was now decided, this was going to happen, but I think there's a lot of details still to be worked through.
Hello, Richard. I'd like to take you on your notion of aging. You started out your sketch of all the problems of this world, and rapidly ended with the conclusion that demography is one of the driving forces of all the problems of our healthcare system. Now, I think if you look at the international evidence for that. There is no evidence whatsoever that aging is a major driving force in healthcare costs. Actually, it's surprising that aging only explains a very small share whatsoever of the increase in healthcare. So I think we have to be careful in blaming the elderly. In particular, I feel myself almost aware of that, as the source of of all the problems we're facing here. Actually, maybe what we can see, it's time that we would redefine the very term aging, not as the share of population over 60 or 65, as we've done for over 130 years, because of Bismarck started his aging his pension system at that time in 1883. But we now have to reconsider aging, as particularly in healthcare, let's say as the share of population over 80. Most of us between 60 and 80 are healthy and happy and totally independent. So you can't blame that growing share of the population, still very low in Ireland, of the cost of healthcare, and even the share of over 80s in Ireland is very small. It's a very small number. So I would say get out of the notion that aging are the ones, demographic changes are the ones causing the problems of healthcare.
Thanks for that. Yeah, you're right. You're right. I didn't say that aging was the driver of health costs. I said that it's an important change that's happening to Irish society, like many others, that has implications for the provision of health care, which it does. Chronic disease management is one of the biggest challenges that many societies face. And as populations get older, the proportion of chronic disease within their population increases too. And that has implications for the types of work that is done within healthcare. That doesn't necessarily drive up costs. And in fact, it might be that those costs are borne in primary care. And what you tend to find, and in fact I've done research on this, is that if you look at the costs of different age groups in terms of overall healthcare use, you tend to find that older people, although they are more likely to interact with healthcare, their relative costs when experiencing healthcare are actually lower than for younger age groups. And it stands to reason that by and large, much of this is done within the context of end-of-life care, because a high proportion of all the costs that anyone will bear are in the last 2 years of life. But a young car crash victim in a hospital costs a great deal more than an older person dying in hospital. And that means that, as you say, overall healthcare costs are not being pushed up necessarily by population ageing. It does have an effect. I mean, I think it's something, 1 to 2% increase in healthcare costs because of ageing. But I think the implications are much more to do with the types of healthcare systems that we actually put in place. And there are certainly implications for that. I'm certainly not aiming old people.
Thanks to you for that. Well, that we have another question here. Thank you.
Sorry, Richard, I'm just wondering, do you see a problem with the prospective care purchase? We say, for example, what we have with the toll bridges here at the minute, where the government had guaranteed a certain amount of traffic and now we have to pay for it, even though that didn't materialise. So do you see that as being a concern?
How you purchase care prospectively is a complicated business that you're going to have specialist agencies involved in carrying out. They're going to have to write tight contracts, and they're going to have to think about all the unintended consequences of writing those contracts so that they get the best deal for the taxpayer in terms of work done within those either hospitals or other units. It is always possible within any financing system that you have outcomes that you don't desire. There's no perfect contract. All you can do is try to put in place a good structure to begin with, which then has safeguards that mean that you can sort of edge towards maximising outcomes, but you never reach them. But what we do have to think about here is, for the body that does the purchasing, they're going to have to invest a lot of resources in doing that appropriately. And they're going to have some very smart people thinking of the implications and look at the evidence and base their contracts on the evidence. The way that contracting is done at the moment through some of the insurance companies, health insurance companies, is not particularly effective. And it's quite wasteful in many ways. And it has led to an acceleration in healthcare costs that we could have avoided. So this is an area that's going to need a lot of work. It's not simple, and it'll never be perfect, but we could do a lot better than we do at the moment.
Michael Begley of Clare County Council. We've had a lot of talk of primary care, and I want to ask the question, is there any plan in place as to how we intend to set up a proper primary care facility? Based on the figures you gave of 56% of the budget presently going into primary care, which by and large is the normal GP surgery, are we waiting for the same system as it appears to have developed in the nursing home end of the medical system, where we're waiting for private individuals or consortiums to set up on greenfield sites nursing homes as we've had, and we find now that the system is gradually working towards the elimination of the local district hospital, the local public nursing home, as it were. I'm not sure if I'm giving the right titles to those, in favour of channeling into private system. Is the same sort of system envisaged for the development of primary care? Or is there going to be an analysis of what's available? And there are some excellent primary care centres set up by private GPs who deal with, some cases, all private patients, in other cases both, and that those facilities are not being fully utilised. Are we going to look at those, see where they're located, and can they be used? I suppose the final question is, to what extent is the government intending to put in money, funding, to develop? I'm not talking about the operation of them and what facilities should be in them, but the actual provision, capital investment, in other words, in setting up the primary care system. Thank you.
I can give you a very brief answer to that. Prime Minister, this is all unclear at the moment as to how this can be carried out. The government policy up to date has been very ineffective at providing the structures in primary care that were envisaged in the 2001 primary care strategy. So this is an area which I would like to know a great deal more about myself.
Okay, we're going to take a break. I'm sure everyone will be pleased to stretch their legs.